Wow. So welcome everybody. My name is Annalise Morris. I work here at Health Translation SA as one of the project officers. Welcome to webinar 2 for our implementation science initiative that's running throughout November. I'd just like to acknowledge before we begin that we're meeting, or I'm certainly meeting, on the lands of the Kaurna people, and acknowledge them as traditional custodians of the Adelaide region, recognising their cultural, spiritual, physical and emotional connection with their land. I'd also like to honour and pay respect to Kaurna elders past and present, and all generations of Kaurna people into the future. I'd also just like to acknowledge any of the other lands that some of you may be meeting on elsewhere, and welcome any Aboriginal or Torres Strait Islanders that we have with us today. So as said, welcome to our Spotlight on Implementation Science series. So over the course of November, Health Translation SA is running these webinar series. So we've got 4 in all. And we're also sharing some links to training opportunities, other videos, publications, and other resources that we hope you'll find useful to learn more about implementation science, how you might get involved and upskill in this area, because it's a really important part of the translation process. So we want to get people learning a bit more about it. So up on the podium, as it were, today, we have Craig Lockwood from Joanna Briggs JBI Institute, sharing around evidence implementation and implementation science, and Natasha Howard speaking about implementation science in Aboriginal health. Which I will introduce you in a moment. Just before we get started though, I think most of our attendees may be familiar with Health Translation SA, but just very briefly, I wanted to just share with you our purpose as an organisation. So Health Translation SA aims to accelerate research findings into healthcare practice and policy, and increase whole of system research translation capacity to improve the health of South Australians. So really what this initiative with our Implementation Science Month is all about is to look at that, I guess, whole of system translation capacity. So we're wanting to build skills in a whole range of areas that are important to get that evidence out into practice and policy. So this is just one of the things that we're doing to hopefully increase the capacity of people out in our networks across our partners. And I also just want to acknowledge that HCSA works with our partners and other stakeholders, and that partnership and collaboration through the organisations that we work with, so the universities, primary health networks, SA Health as a whole, and the Commission on Excellence and Innovation, and the Aboriginal Health Council, and SAMRI here, is absolutely central to everything we do to work together with our partners. So we just want to acknowledge our partners in what we're doing, and their input into this initiative that we're running as well at the moment. Just quickly, I'll just do a bit of a promo as well. We do have 2 more webinars coming up in the rest of the month. So if you're enjoying what we're talking about today, then please sign in for the next ones. So to kick off today, we are going to hear from Dr. Craig Lockwood. As I said, Craig works at JBI. He's the Program Director for Implementation Science, postgraduate coordinator for research degrees, and the chair of the JBI Qualitative Synthesis Methods Group, if I can get my words out. Craig's research interests include evidence implementation and qualitative synthesis from a theoretical and pragmatic perspective, and he's responsible for maintaining the online portal JBI-COnNECT for dissemination and implementation best practice. So thank you very much, Craig, for joining us today. I'm going to work the magic of the internet now and stop sharing my slides if I can. There we go, there's the button I'm after. And I will invite Craig to unmute himself and let you take over and share your thoughts with us.
Right, good to be here, and thank you for the invitation. So I hope everyone can see my my opening slide there. It's always a pleasure to talk about things related to implementation.
Sorry, Craig, I'm going to interrupt you. At the moment, I can see your face, so you might just need to check your screen share to see if it's...
This is a terrible thing if you can see my face. We really have to correct that.
It's lovely to see you there in the flesh. So.
Is that better?
Perfect. Yep, now I can see you. Thank you.
Everyone will have a better day now. So yes, it may be chuckle to see implementation science or evidence implementation with a question mark. And I I think there should always be good questions in this field. But really what I'm doing is I'm talking a little bit about JBI, who we are, where we've come from, how we think about implementation, and then segueing that into some work that we did on behalf of Health Translation SA around language used in implementation and language related to research utilization, and then try to sort of like look at how do we bring some of that together in some future thinking. So you've got me for roughly the next 20 minutes to talk about that. So for those of you that might not be familiar with us, JBI commenced life in 1996. We moved into the University of Adelaide in 2010 and have always had a focus on working with universities and hospitals around the world, starting in Australia and New Zealand, but really with a model that's centered around the role of collaboration and partnership and working together to achieve outcomes. And this year we get our big boy pants, we turn 25. So that's kind of exciting to be part of something for 25 years. Our vision and mission are fairly simple. Our vision is for better evidence, better outcomes, leading to a brighter future for patients, people that use the healthcare system and the people that work and support it as well. And our mission, so the way we want to achieve this is to promote and support evidence-based healthcare. We don't do it. That's what clinicians and policymakers and other people do in that sense. But in speaking before about having a collaborative model, that's about creating evidence for policy and practice to inform decision-making, where good quality evidence becomes culturally inclusive and clinically relevant to local knowledge needs. And so that's the basis of operations, both here in Adelaide and around the world, really. So here's a little snapshot of who, what, why, how. I got all that backwards. Who, what, where, how, and why for JBI. And you can read more about that on our website if you like. It's underpinned by a very simple premise, and that is if an organization is committed to creating content and enabling the development of high quality evidence to inform policy or practice, but they do that without the adjunct tools, resources, and knowledge that actually facilitates or enables implementation, then that's a failed model. And we don't want to work in a failed model. We all know passive dissemination is only good for academic credit on a CV, but it's not actually great for impact. So instead, JBI works to this kind of framework because we're interested in active dissemination and in partnering good quality evidence with low cost, accessible tools, resources, and training opportunities so that people who want to use evidence or in practice or decision making have sustainable opportunities to do so. There's many different definitions around evidence-based healthcare around the world. All of them are reasonably similar though, if you unpack them, in that they see evidence-based healthcare as a decision-making process which brings together particular kinds of knowledge. And I think we often overemphasize the empirical knowledge or the best available evidence component, whereas in practice, the empirics that relate to something, or even especially in policy, the empirical data on an intervention or a process is really just to be used on balance with other domains in terms of, for example, client or even population level preferences for an intervention, the specific aspects of the context, and of course, professional judgment, which is a complicated thing in and of itself. And so having interest in language, in nomenclature, and how we generate meaning around language has led us to really look with renewed interest at the way we think about knowledge translation or research utilization and where all this language comes about. And it's obviously a shared interest with Health Translation SA because we were in discussions with Akushla, wow, it must be 2.5 years, 3 years ago now, around wouldn't it be good if we could do some preliminary work at looking to try and bring some of the language together to help make sense of it and try and present some sort of initial offering which attempts to unify the diversity of words and language we use around knowledge translation in particular. And could there be an intrinsic structural approach to considering that sort of language? Anyway, it was an inspired conversation, and it led us to do some work. So we did a rapid review with Health Translation SA on managing meaning and navigating the nomenclature around research utilisation. So just briefly on the objectives, I'm not going to go into the methods. If you want the report, then it's with Health Translation SA, and they are welcome to share it with whoever they wish. But you can see our objectives on screen. We wanted to scope published literature, existing taxonomies, key websites for definitions and descriptors, and terminology related to research translation in order to develop a synopsis of those. And what drove the work was this question: what are the classifications, the schemes, the nomenclature and taxonomies within health contexts in Australia and then more widely internationally? Now, of course, there's so many word variations. A lot of them you do have to ask, what is the value or purpose of this variation in language? And maybe there are strong, locally contextually relevant reasons for it. But I will just show you some of the data just to help unpack what we found. So you can see here, knowledge translation, far and away the main term of usage. And we might even consider that an umbrella term, for example, because knowledge translation could infer, an overarching approach to the conceptualization of research utilization. And then there are many branches underneath that, which are far more granular and specific about particular activities. But this short list that you can see here represented the majority of the use cases across the included literature. And underneath 4%, it actually dropped off down to 1% or even less than 1% on frequency of usage of different terms. But it was interesting to see this level of variation. So evidence implementation, knowledge utilization, research utilization, knowledge to action, which most of us would be familiar with as a model, was also used, as was research to action. And these had very minor kinds of frequencies attached to them. There was 10 key national and international groups that we included in a web-based search. And those showed, so these were key groups in the evidence-based healthcare world or movement. And you can see that these had a strong preference for knowledge translation as their preferred term. But again, other terms were used without any real distinction in the application or functionality of the use case for those different terms. But it was interesting because there were, in some cases, differences in how those terms were being used. And we know anecdotally approaches to health research translation vary internationally. Stakeholders have developed strategies that are in line with local and national policy frameworks. And our review identified 5 sort of high-level approaches. So that's the end of grant, or you might call that a traditional approach to KT, end of grant. We've finished our research, now let's do some KT. Integrated KT, which is a unique and different approach that's sort of continuing to become emergent and more dominant in the global narrative. And then conceptual research was around sort of the pragmatics of healthcare or policy delivery through standard operating procedures. And it got a little more theoretical from that point on in terms of symbolic use of research as well. But pulling all of this literature together led us to think, how could you or would you frame this so that, what if the reader is not completely au fait with knowledge translation or research utilization, and they want to be able to understand whether the term they're reading is related to other terms that have similar meanings, and whether that could be framed in a useful way for people as part of their language and part of what they're writing. So we spent some time trying to reconceptualize what we'd been reading and developed what you can see on screen now as a concept map. Look, I'm just going to check the chat because I'm paranoid about missing something. Oh no, there we go. It's all good. So we created this concept map to help categorize the term, trying to illustrate the relationships and similarities and differences in different domains. And we came up with what we think is maybe too simplistic, but pragmatic and reasonably simplistic, so that if somebody at a really broad level just wanted to know what is all this language around KT and what does it mean, so I don't trip up on it. And so fortunately, we found over time we were able to unpack a use case that made sense to us, and I hope makes sense to you as well, which was that there's process-related terminology, so translation, utilization, action, implementation, practice. So these are about what to do kinds of constructs, using evidence to inform healthcare or acting on the evidence. And so that was one whole body of literature. And then the second, we were actually really able to frame down and go, actually, in terms of how, so how do we do, or how do we investigate knowledge translation? Those are research processes of investigation and inquiry rather than application. And so that was about exploring and explaining or understanding aspects of KT. So really the investigation of process. And so that we defined as the how to do. And I know it's very simple, but sometimes simple things can be elegant and useful. So then if we have this kind of understanding of language and how it can be used, then it's interesting to look at, well, does that actually work and how does it work? So I'm modeling this last segment of my talk really on what we do across the Institute and how that comes together. Because I started by talking about if you just do passive dissemination, then you've done passive dissemination and no one's going to get access to that. But that if you're creating content and information, you really want to use active dissemination and support that knowledge that's been created with tools and resources and opportunities for people to upskill so that they can become users of that evidence. And so that's what I'll just talk for a minute about in terms of models, methods, and mechanisms of action. So this all stems from, some fairly, I think, sort of simple understandings that we need knowledge in order to act professionally and appropriately and make good decisions, but knowledge is not the same as action, and knowledge is not a guarantor of action either. In fact, we need a number of different things, and this list of 3 is not by any means definitive, but we certainly do need interventions that are informed by understandings of human behaviour theory. There is a role for leadership in a change process. And although academics and researchers and scholars like to investigate complexity, we also need change processes that can be routinely embedded in clinical and policy settings where the process is not too complex. So it's got to be accessible and it's got to be low cost and it's got to be able to be sustainable to some extent. And I think that's a debatable list, but I felt that we got to start with some kind of common baseline, and so that's my common baseline. This is informed by the JBI model, so you can see we care about diverse types of evidence in the middle. These are meant to inform global health. Evidence is created through research, that's the green section on evidence generation. And then synthesis brings that together, systematic reviews of various kinds and methodologies to answer different kinds of questions. Transfer, which is often around education, the transfer or the exchange of knowledge and the movement of tools and resources, leading to implementation, which we hope has a beneficial effect on global health through local settings, of course. So in JBI, we have a particular model and approach, which I'll put up on screen next, that most of you are probably familiar with the JBI model. Very helpfully, there's a huge number of superb models for implementation available from around the world. Pretty sure everyone in this particular meeting has heard at least of knowledge to action and the Paris model. And there are many, many more that can help guide people in their thinking. Methods, quality improvement, case study, evaluation, implementation, research. So what does it look like in terms of a mechanism for action? I'll just use my last couple of slides to show you something about that. Mechanisms for action in thinking about implementation where you've got accessible, low-cost, sustainable approaches help answer a particular question, which is not how do we implement X, it's who needs to do what differently in order to, right? Because we want to change structures and processes of care in order to improve overall patient outcomes. And so there's a range of strategies for doing that. In JBI, most of those strategies are based around education or knowledge transfer. Again, that's part of the process of if you create evidence, but you don't provide the vehicle or the framework within which people can take it up, understand it, evaluate it objectively for its quality, and then be skilled and trained in using it, then they miss out and you miss out as well. So education and training in implementation is a specialist focus of JBI, as is clinical leadership. And we're blessed in South Australia with a huge amount of skill and resource in those fields. In JBI, we supplement that skill and resource with specialist software that is designed to enable and facilitate clinical audit or quality improvement type projects, but that are underpinned by evidence. And again, I want to come back to a discourse between complex interventions and what are sometimes seen as simple interventions. And audit and feedback is often seen as, well, it's nice, but we know everything there is to know about it. And it's fairly simple. I'm looking for something a bit more sophisticated, or, where I can modify more variables in a different way. And I'm not actually sure that's entirely true. So this is just a flowchart, and it's really granular on my screen. So apologies for the poor quality picture here. But this is a quote unquote simple audit and feedback project. And you can see there's a need for organizational leadership and buy-in up the top. So this is the pathway that a clinician had to take to get through an audit and feedback project, navigating and negotiating organizational leadership, a lot of stakeholder engagement, really digging into the local context and a pre-planning process, then piloting, all of which had to be underpinned by educational interventions and strategies to be responsive to emerging knowledge needs. And so if you follow that pathway, this is really interesting work for a clinician to be involved in. And it was intrinsic to a successful project based on that individual knowing about implementation, being able to build organizational bridges that link with professional priorities and clinical leadership. So the kinds of things that we have in JBI, and I just wanted to take an extra 2 minutes probably to just flesh this out a little bit for you, is the commitment to providing high quality evidence that people can access as part of their own decision-making process. With us, it begins with a database of evidence-based practices, and you can read more about that if you want to. We host a number of journals and handbooks that are also around opportunities for academics and scholars to participate in implementation or knowledge translation work, and then publish it in journals that are specific to that work. And equally for groups that are interested in then how do you bring these pieces together into a comprehensive way, we have a program called Endorsement. And endorsement is about organizational attribution of knowledge translation, whereas audit and feedback is often an individual getting involved in that. So as part of being a centre or a collaborator with JBI, organisations can become endorsed by developing or using resources that enable them to model a commitment to evidence-based healthcare, continuous quality improvement, and capacity building. So there's probably a bit more that could be said about that, but I know I'm just over 20 minutes. There is a lot more about JBI. There's a lot more to be said and done in this state on KT, and I'm really glad to have had the opportunity to share some of that with you, and I look forward to continuing that conversation. Thank you, everyone, and I'll stop sharing my screen so that we can go back to the main room.
Thank you, Craig. That was great. Let me just click my buttons as well, make sure that the recording's capturing what we'd like. So I think it's, some of the messages that I'm taking out of what you've just shared there around that diversity of language, but really supporting a working knowledge of the terminology and making it meaningful is really important. And I really like that quote in there around knowledge is not a guarantee of action, and looking at what are the services and tools and methods that we have to actually change those structures and processes to improve the care. And I think there's some interesting takeaways from my perspective, and I think JBI has got such a strength in those different tools and methods that to help people along that road. So that's just that was my takeaway. I would also just invite anyone that's attending today now to either pop in the chat if you've got any questions, or you can put your hand up and we can unmute you and ask any questions of Craig from what he's just presented for us. I need hold music while people think and type.
It was obviously an amazing talk, and everybody just captured everything. My first time ever. This is fantastic.
Absolutely. We need not say more. We'll just wrap up there. So, we've got a couple of people just saying thank you. That was helpful. So that's great. So if we don't have any burning questions, we'll carry on, and then you can. Craig will still be with us at the end of the session as well, and we can add any further questions from there. So. Thank you. That was fabulous. So I'd now like to hand over to Natasha Howard. So Natasha is the platform lead for implementation science at the Wadley-Paringa Aboriginal Health Equity theme here at SAMRI. The platform incorporates a systems view and privileges Indigenous knowledges to deliver mixed method interdisciplinary perspectives, aiming to generate policy and practice-based evidence on the social determinants of health. Natasha's experience spans both the health and social sciences, applying population approaches to investigate how social and built environment enables and promotes cardiometabolic health and well-being. Natasha has been active in advocacy and mentoring of the local population health community in both research and practice, and we're delighted to welcome her to speak today, having a look at a lens from Aboriginal health equity on implementation science. So thank you, Natasha. I will let you take over.
Thank you, Annie. Okay, can you see everything okay before I go any further? Okay, all right. So thank you for the introduction and the opportunity from HTSA to present today. As always, I'd like to firstly acknowledge that I'm on Kaurna country and pay my respects to elders past, present and emerging. I'd also like to acknowledge any Aboriginal or Torres Strait Islander people that are listening today, and those that are meeting on other lands as well as the Kaurna country. I'm a non-Indigenous person who's grown up on Kaurna country, and it's been an absolute privilege to share that with my family. I have a public health equity background and have been working in Aboriginal and Torres Strait Islander health for about 8 years now. I'm situated as the platform lead in implementation science at Aboriginal Health Equity in SAMRI. For those that have not been to SAMRI, you should not miss it on the North Terrace. It's a unit that was established by Professor Alex Brown, and you'll see my other colleagues there, Odette Pearson, Kim Murray, Carla Canuto, and Associate Professor Peter Azzopardi. We really are a unique unit with over half of the group identifying as either Aboriginal or Torres Strait Islander, and we really have an important job to doing in terms of addressing the huge gaps that are there for Aboriginal and Torres Strait Islander people. The work that's occurred here in SAMRI started with asking the community what they needed in terms of priorities, what research had already happened across the state, making sure that we weren't coming and asking questions that weren't important to community, but also had already been asked in some way. So the next steps report that was done back in 2015 really is a guiding document still for us today around some of the priorities for Aboriginal health research and a starting point to thinking about the questions at hand. This also led to thinking about development of ways of working and the principles to conducting that research. And so many of you will be familiar with the South Australian Aboriginal Health Research Accord that is about making sure Aboriginal research is in Aboriginal hands across South Australia, and all of the universities and SA Health are partners and signatories to that accord. And so you'll see some principles that are listed there. And I think as I go through some examples of projects from implementation science, you'll see me talk about community priorities, reciprocity, the aspects of translation and involvement of our partners as we go. So I guess that's the key things to watch out for in thinking about how we do research in implementation science Aboriginal way. So we've talked a lot about implementation science already today and the different definitions. If I'm thinking about what we're doing here in Aboriginal health equity, the definition that I'm thinking about is applying strategies and methods to further understandings on how we can take action on social determinants of health and other critical issues that are of importance to Aboriginal health equity, but are also defined by the priorities for community and stakeholders. It also then is methodologically driven, therefore we're privileging Indigenous knowledges, making sure we're incorporating mixed methods and systems thinking in any of the project design. We're also aiming to generate transformative health equity solutions, and that comes through our embedded research practice partnerships and ensuring that there's rapid translation of that with our partners. The implementation science platform here at SAMRI is really aspiring to undertake transformative approaches. We're wanting to incorporate those system thinkings, bringing the right people, the right disciplines to the table when we're thinking about the actual new projects and collaborations, and always thinking about how we can incorporate those Aboriginal worldviews. We're integrating the existing evidence. The last thing that community need and tell us to do is not start again at new questions and thinking around that. So we can be establishing what we already know in a co-design process, but ultimately also co-creating new knowledges on how then we can intervene with social health and community settings. We want to make sure that we're developing, implementing and evaluating tools, processes and strategies along those research projects. And I'll give some examples of that today. Along the project journey, we also have rapid translation of research ultimately to the community, putting it back in their hands, but also to important key stakeholders, including policy and practice. Many of you would be familiar that the Aboriginal holistic conception of health is beyond just the physical conception of health. It includes social, emotional and cultural wellbeing of not only the individuals, but also the communities. And the framework there in social emotional wellbeing from G and colleagues outlines the historical and political and social determinants that are shaping Aboriginal health and wellbeing. When we're thinking about the social and cultural determinants of health, things like housing, education, material circumstances, we know that they're really shaping the outcomes of health and wellbeing for Aboriginal communities. Around a third of the social determinants are influencing those health outcomes in some of the anecdotal data that is there from pulling resources. My Life, My Leave was a consultation report that was done thinking around the needs from community to take action in social determinants and cultural determinants. What we know is that we understand that they are shaping and influencing health outcomes, but we really don't have enough evidence around how to take action on the social determinants of health. I think all the presentations that will come up in the implementation webinar series will be talking about complexity. We understand these systems, that they're multi-level, that there's complexity at play, and that we need to be thinking about how you do it and what's best and what works. What we know, and I think Del Casino and Jones' quote here thinks about thinking like theoretical approach, there is no one single one that will be able to resolve answers to thinking about the socio-spatial inequalities that exist. So different communities, different people experience different ways of understanding the problems at hand, and we need to be thinking about what the best way is for that problem at hand. And then therefore, there's no one method, and the traditional methods of thinking about how we understand those relationships, particularly biological, social, behavioural and environmental factors, need to be expanded. We need to innovate and think differently, and there's no other area that I think that's most important is in our biggest area around Aboriginal and Torres Strait Islander health and the gaps that exist for community. If we're thinking about taking action in terms of public health, and the last presentation, Craig talked about the decision making. Well, an example of Aboriginal and Torres Strait Islander health, we're making sure that we've got the population characteristics and the needs, understanding what we already know about what's happening for the community, as well as the evidence that already exists, and making sure we've got the right partners and the people and the disciplines at the table. And then ultimately making sure that the decision making is in the hands of Aboriginal and Torres Strait Islander people, communities, the stakeholders and the organisations that the questions are of interest for. And that can vary across every context. Those partnerships are super critical to absolutely doing everything we need to do in implementation science. And the concept of learning healthcare systems at HTSA themselves have indicated, in their impact framework, that we need to enable a statewide learning health system. But it requires us to have opportune settings where we can be embedding those evidence base, and we've got really great partners in Aboriginal and Torres Strait Islander health. Particularly, I'll mention the NALHN collaboration in a couple of the examples. And in their strategic plan, they're talking about being committed to a learning organisation. But ultimately, we want these learning healthcare systems and the intersection with implementation science to be combining the wisdom and experience of the community, of those practitioners, both the Aboriginal and non-Indigenous staff, and also the research team. We're wanting to generate evidence that is highly relevant to the needs of the community based on those community priorities, but also making sure that it's led by right from the conception to thinking about the design, who's involved, what governance and leadership is needed, and how you would make sure that you co-create the implementation of whatever strategy you've come up with in that co-design phase. And everything through to making sure the commitment to rapid translation, getting stuff back to people as soon as we're knowing about it, so that that can take hands into the community or the stakeholders that are relevant. We've talked about partnerships with NALHN, and in particular, I'd like to highlight the Northern Adelaide Local Health Network. The Aboriginal Health Framework and Action Plan was released last week, and notably within that, so implementation science is situated here in Samri, and it's been mentioned as a partner, being able to enable research as a priority for community and be able to, be a mechanism to meeting around translation and influencing their service delivery. Within that framework, there's also an Aboriginal health story that talks about the layers of importance around the community, the leadership, the influence of social and cultural determinants. But important to the work that we're doing in implementation science here in Samri is the meeting place of Aboriginal knowledges into practice. And so the green component of the Aboriginal health story is about us meeting as the research team with our partner in NALHN, being Waterpuru Aboriginal Primary Healthcare, and the Lyle McEwen and Modbury hospitals, and making sure that we're supporting ways of working, co-creating solutions, and working out ways to translate that in real time into the health system. Here at Samri in Aboriginal Health, there's the Implementation Science Platform, as I mentioned, and we've got a couple of research initiatives that I'd like to highlight today. The particular two areas are around identified needs in diabetes and complications, and the one I'll highlight is diabetic retinopathy, and the second is around unmet social cultural needs. So there'll be two projects that I'll give some highlight of the work that's being done by my team. Diabetic retinopathy. So this is a busy slide, but it is purposeful in that it is a journey line in how we came about getting some funding and then starting an implementation of a project. So the large-scale Aboriginal diabetes study led by Professor Alex Brown is looking at determining better ways of preventing and managing diabetes. And one example in the northern areas that we did undertake that study back in 2019. And it was through the processes of our translation and commitment to feedback to the health service that we met with the governance committee, and then were able to present the data that we had around low eye examination rates. And then we were able to then see like what could be done immediately, what relationships needed to be established. We partnered between Flinders, the Australian College of Optometry and the Aboriginal Health Council. And then we thought about ways to be delivering some optometry services in the northern region. At the same time, the opportunity of a Medical Research Future Fund grant occurred with the Indigenous Health Round, and they happened to have a focus area around avoiding preventable blindness, which obviously we jumped at to be able to write an application. And this is a collaboration between Flinders with Professor Jamie Craig, and here at SAMRI we implement the Aboriginal Eye Health Project. We're going to be able to deliver this initiative across 3 sites, an urban, regional and remote site. So the project aims to co-design a community-led eye health care action plan. And so again, we're not taking new ideas without thinking about what's already been done. So we have knowledges from the Aboriginal Diabetes Study and what was happening in terms of eye health and rates of diabetes and diabetic retinopathy, as well as other key eye health surveys, and understanding what already exists on the ground in these services in terms of equipment and referral pathways, talking with practitioners, and ultimately co-designing the engagement to develop what an action plan design plays, and that will be replicated across regions. Ultimately, we want this plan to be part of their usual care within the healthcare system. And so it is community-led by their governance and their leadership. And what we know to date is that the service delivery has always been the focus in screening initiatives around diabetic retinopathy. And if we're thinking about things being multi-level and needing more the complex system, we're needing to think about all these other cogs in any implementation plan for us to be successful in increasing screening rates within community. And obviously we want to make sure that we evaluate what worked, what didn't, and make sure that we understand that at the local context for each of the sites. And so we're undertaking developmental evaluation, thinking about modifying that in partnership with our collaborators, and making sure that we're adapting any plans, working on what that looks like to refine and measure across each of the stages. Ultimately, we want to strengthen the service system capabilities, the screening rates and treatment coverage, and the vision related outcomes overall across each of the sites. But at the same time, we're also doing rapid translation, and that could be as basic as thinking about fact sheets around diabetes and eye health care, to thinking about promotional material around transport or access to the services, who is the optometrist, and what else is happening in the eye health plan that is being delivered through the site. But ultimately, the goal is in a project like this, making sure that even though it's localised in terms of the context in which the site is being delivered, we want to make sure that we're taking some key principles that could be delivered across other settings and contexts, and ensuring that we understand those principles to a culturally appropriate, integrated and sustainable DR screening program for community. Secondly, I'd like to highlight another example around unmet social and cultural needs. And this also led from the Aboriginal Diabetes Study, where we were thinking about aspects of material circumstances and income, and how much money lasts for community members in terms of their commitments and their needs around the social and cultural determinants. What initially happened in this space was a concept of no survey without service. So we're working with our study participants around diabetes and its complications, but ultimately we wanted to be able to take some action as well. And so those individuals and families that were in the health study actually needed some immediate support. And so what we were able to do through funding from the Wyatt Trust was develop a pilot initiative called the Cultural Pathways Program, where we were able to pilot tools around screening, goal setting, brokering, connecting to social and health services. This also then led to incorporating that pilot data into an application to the NHMRC, and we established a program particularly focusing in the northern region of Adelaide, and its Kaurna name is Tangawilta Burku Kawandilla, which means strong community in the north. And we have brought together leaders that are across those partner organisations, across social and health services, as well as strong Aboriginal and Torres Strait Islander leadership. We've also incorporated a role in terms of a senior engagement and knowledge broker role, which is Eugene Warrior Jr. And he is an essential role in being able to broker between the research setting, the workforce and the community. So similar to the other approach, it is a co-design, implement and evaluate model. Ultimately, we want to be thinking about multi-level strategies with the community and the social and health service sector as well, and be thinking across those different levels on implementing strategies and initiatives and ensuring that we're evaluating not only those strategies, but the impact across the different levels of the system. Again, as we always say, we don't want to start from scratch. There were lots of work that was done already with community around case studies on social determinants of health and health service delivery. Work that's been done with Lowitja funding around stress and staying strong in Aboriginal and Torres Strait Islander workforce. And I've mentioned the Cultural Pathways program. So what we already knew around screening, brokering, connecting between social and health services. We also needed to make sure we gained new knowledges, and particularly around the local context around the northern catchment. So there was a co-design process initially in exploring the needs, the success stories and gaps, and thinking about those partnerships. And then being able to combine what we already know and those new knowledges in terms of the co-design in thinking about what are strategies and what an implementation plan would look like. So when we're thinking about all those different multi-level strategies, they're going to come across the broader social, political and historical context. They're going to incorporate the intersections between health and social services, the community at large, thinking about things at the family and kinship network and personal level. So I want to give some examples of how this is going in the co-design phase, where we're, as a research team and our partnership with SAMRI and the University of Adelaide for the project, have been establishing some key partners, one being Wataparuna Aboriginal Primary Healthcare out at Narlan, the second being the Northern Mental Health Alliance, which includes some significant policymakers and organisations and incorporation of lived experience around mental health in the Northern region. And the third example is the Northern Nungas Network. And this actually evolved out of our own advisory group meetings where we were translating our findings back in real time. And one of our stakeholders and advisory group members actually heard the results around needing intersection of the social and health service workforce of people that are working with Aboriginal and Torres Strait Islander community. And they established the Northern Nungas Network, and they've had a number of successful meetings to date. And this is an example where the findings are put into real world practice in the sense of them coming together and meeting and hopefully having some sustainability longer term beyond the life of our research funding. In terms of these rapid translation partners, each of them will then have examples of strategies and things that we've done with them that we'll be then able to evaluate over time. I'll give the example of Wataparuna, where we'll be working in terms of some of those things that we knew about working with clients around screening and broken connecting to health and social services, as well as the importance of the workforce in anything that we do within the primary healthcare setting. The Northern Mental Health Alliance, we've been able to share our results today and make sure that they're feeding back, particularly those ones around the intersection in the health and social service sector and at the community level. And so we are talking about the things around what that alliance could do in terms of strengthening access to culturally responsive mental health services and also strengthening aspects around cultural determinants. So our findings are being put into their real-time meetings, and discussions and opportunities are already arising out of that collaboration. The Northern Nungas Network particularly will be able to help us strengthen the service connections to support Aboriginal and Torres Strait Islander community clients, as well as being an opportunity to get those partners together and hold events. And they're things that community have been telling us that we need more of in the North. The example of Wataparuna and primary healthcare I've touched on, but this is an example of where we'll work with that site to develop an implementation plan and then evaluate those multi-level strategies. So thinking from everything from workforce to strengthening those connections between the health and social service sectors that they work with at that service level, and really a strong focus on thinking about what do we do to screen around social determinants and broker those connections to other services. Ultimately, we want to be able to evaluate what not only have we implemented, but the impact that that's had to both the service, but also the broader community. So there's some really obvious ones around the process indicators of how many people you're seeing and what screening and what's happened in terms of their referral and follow-up. But we also would want to understand again where people are at in yarning with the clients and the workforce, and ensuring that we are meeting the needs and what impact means for the Aboriginal community. So we've talked a lot in those two examples about the intersection between implementation science and examples in the learning healthcare system. I think, there's lots of opportunities with an Aboriginal and Torres Strait Islander health to be thinking about moving with scientific advances, thinking about what new technologies like artificial intelligence, aspects like precision medicine will have in terms of thinking about what ethical, social justice and cultural perspectives there are, and how we could be applying those within Aboriginal and Torres Strait Islander health to ensure that we're addressing critical needs of Aboriginal health equity. I'm obviously the lead of an amazing team here at SAMRI in terms of implementation science, and I acknowledge all the hard work and dedication both staff and students and our collaborators have and their commitment to moving this agenda forward. And I thank you for the opportunity to present today of a touch of what we get up to. Thank you.
Thank you, Natasha. That was great. It's a whirlwind tour because I know you guys are very busy and you've got a lot of projects to pick between when you're trying to highlight things. So I think a lot of what you're saying there, I'm thinking back to what Gillian presented at the first webinar last week around acknowledging and working with the complexity and not trying to simplify things, and those examples you've highlighted around the multi-level strategies and how to actually engage with that complexity is really interesting. So thank you. And I think also that model that you shared around the co-design, implement, evaluate is an interesting one that we haven't probably seen in those terms before. So thank you for that, because I think it's there's some things that we could really dig into at different stages of those those processes. So again, I'll put it out to the attendees. If anyone has any questions for Natasha whilst we're here, either pop them in the chat or pop your hand up and we can have a Q&A. So anyone? Again, I'll have to put my hold music on to start.
That's again, we covered it all. No, it was very much a whirlwind tour of things that are happening in this space.
Yeah, and I think also the slide that you've got on the rapid translation strategies and thinking about some of those ideas about how we bring translation sort of activities into the work earlier on is really interesting. So I think I'll be going back and looking at a few segments of that as we go. So, all right, thank you. Speaker, there we go. So lovely. All right, well, if there aren't any questions coming through, let me see. Yes, again, we've got thank yous coming through for you, Natasha. So interesting and valuable work. So thank you for that.
Thanks, Carmel.
So I'd like to, Craig did have to disappear off to a meeting, but I will just thank Craig Lockwood again from JBI and Natasha Howard from Aboriginal Health Equity here at SAMRI. And thank you also to all of the attendees for joining us today. I hope you've had an interesting session. This webinar and the rest in the series will be available on the HTSA website in the coming weeks. So hopefully if you found this one interesting, you might be interested to join us again. So as I said at the start, we do We do have 2 more webinars in the series. So next Monday, on the 15th of November, we'll be looking at how we actually apply implementation science in policy and practice contexts. And then on the 22nd, we'll be looking at what now and what next. So looking at how implementation frameworks can be improved to improve patient care, and some health research focuses from Alison Kitson and Saravana Kumar in that session. So yeah, we've got plenty happening. If you haven't yet joined our mailing list and you're wanting to hear a little bit more, not just the webinars, but also on some of the other resources that we're sharing, which will be publications and journal links, as well as some other videos and some work that the other translation centres around the country are doing, then please drop us a line to inquiries@healthtranslationsa.org.au, and we'll be able to link you up with a lot of those resources. So thank you again, everyone, for joining us, and we will hopefully see you soon. So thank you. Enjoy your 2-minute early minute. So